Welcome back to Discussions with Dr. G. I'm your hostess with the mostest, Dr. G. We are back for an episode of Legal, Ethical, and Cultural Foundations of Safe Pharmacological Practice, where we peel back the layers on what makes up the backbone of safe nursing practice, especially when it comes to giving meds. And let me just say, if you ever thought legal stuff was boring, you obviously haven't nearly mixed up 2 painkillers on a 12-hour shift. I'll get to that story in a sec. But first, let's talk about why you, as a nurse, need to know your legal regulations like you know the back of your own scrubs. So, first up, the different DEA schedules. 1 through 5. These are basically the sorting hat for controlled substances. Schedule 1, basically stuff you hopefully never give to a patient. Heroin, LSD. These have no accepted medical use in the U.S., and a high potential for abuse. Schedule 2 is where a lot of folks get tripped up. I want you to think morphine, oxycodone, and yes, that old news article about Adderall shortages, that's because it's a Schedule 2 also. Medical use, but super tightly regulated. Schedule 3, think codeine with acetaminophen, has somewhat less potential for abuse. Schedule 4 and 5, those are things like lorazepam in Schedule 4 and cough syrup with a little codeine in Schedule 5. Now, just to spice things up, let's talk a bit about marijuana, because everyone and their cat seems to have an opinion. Depending on where you are, you'll see a lot of debate about moving it from Schedule 1, highly restricted, no accepted use. Depends on who you ask, right? And some states even ignore the federal schedule entirely. It's wild, and honestly, I'm not here to solve the debate today. But if you read the headlines, it's clear. Policy is on the move, and nurses need to stay in the know, even on stuff that's controversial or in flux. All right, let's keep it rolling. Prescriptions. What actually makes one legal? There's got to be a date, your client's correct information, specifically name and date of birth, the provider's DEA number, actual drug name, dosage, form, route, timing. It's like building a sandwich, except the bread is a legal document. And did you know some controlled scripts can't be refilled and others have strict limits? For Schedules 3 through 5, there are cutoffs for days supply and total refills. And if the order comes in all garbled, like you see morphine and no dose, no route, just vibes, you as the nurse are responsible for saying, wait, what? And clarifying before you even think about popping any meds. Okay, here's a real life scenario. You get a script for a kid and the orders are for a weight-based antibiotic, and it makes 0 sense. You almost give the adult dose, but something feels off, so you double-check the kid's current weight, manually calculate the milligrams per kilogram, and find a major error. Turns out if you hadn't stopped and recalculated the dose, the whole care team would have been in a world of hurt, and so would the patient. Nice catch. It all comes down to being vigilant. Whether it's double-checking for look-alike or sound-alike drugs, or catching when that hydralazine was actually supposed to be hydroxyzine. Yeah, I know, totally different use cases. And remember, there's a real legal and ethical expectation for nurses, not just to give what's ordered, but to make sure it's the right med, right dose, right patient, right time, right route, and right documentation. Those 5 rights specifically, plus all the others, honestly, are your safety net. So now that we've marched through the legal minefields, let's pivot a bit and talk about why we do all this. I mean, yeah, law says one thing, but ethics. That's kind of the invisible force pulling all the strings in pharmacology. We talk a lot about autonomy, beneficence, non-malfeasance, and justice. Fancy terms, but at the end of the shift, it means putting the patient at the center. Autonomy first. Every client has the right to say nope to a medication, even if as the nurse you know it's probably in their best interest. It's not our job to force them. It's our job to explain and respect their decision. Beneficence jumps in, doing good for the patients, weighing risks and benefits. That's where non-malfeasance gets tricky, because sometimes even a medication meant to help can cause harm. I always use the example of anticoagulants, bleed risk versus clot prevention, right? That tension is real, and it's our job to balance it. And then you have justice. Basically, treat everyone fairly, whether they're the mayor or someone who showed up with no insurance. Informed consent is a huge deal. Clients need to be competent, understand what they're agreeing to, they get honest disclosure, they're not coerced, and they actually say yes. I still remember a family I helped working through a power of attorney decision for grandma during a rough hospitalization. It wasn't easy, but everyone felt heard, and we made sure unclear decisions were never just assumed. And of course, confidentiality. Every nurse's nightmare if they mess it up. HIPAA is there for a reason, and the fines, y'all, are no joke. If you don't guard medication info, MARs, or patient charts, you're risking not just your own license, but someone's dignity and safety. Quick tip, never say a patient's med history out loud where anyone but the team can hear. Hallway consults might feel casual, but that stuff can really come back to bite you. All this isn't just textbook. It's what sets a good nurse apart. It's about making tough decisions, respecting boundaries, and maintaining trust every single day. Now, here's where things get even more layered. Culture. You can have all the laws and ethics training in the world, but if you don't know how to meet people where they are, you're not going to provide safe care. I'll never forget the first time I had to talk with a family through a medical interpreter. I was nervous, like sweating through my scrubs nervous. But just taking the time, making sure the family understood the treatment plan in their own language, that changed everything. Suddenly, everyone felt seen and included. Medication adherence. Phew, talk about complicated. It's not just about, did you take the pill? There's insurance hassles. Can the patient even get to the pharmacy? Do their beliefs support Western medicine? Sometimes it's tradition, or maybe it's just that oral meds taste like sadness. Tying that to social determinants of health, like transportation or money issues, we have to get creative. Maybe we arrange delivery or make sure the education is super clear. As nurses, we're always troubleshooting this stuff in real time. And here's something I keep returning to: addressing historical trauma and implicit bias. Recognizing that some communities carry heavy memories of medical mistreatment. Think of indigenous peoples or Black Americans still dealing with the fallout of abuses like forced sterilization or the legacy of the Tuskegee study. Bias can be explicit or implicit, and if you're not checking yourself, you're probably relying on assumptions you didn't even know you had. That's why I make a point to keep learning, so I can recognize my blind spots and make sure I'm really providing equitable care. Anyway, if you're practicing nursing today, cultural competence isn't optional. It's part of making sure our patients are safe, heard, and able to actually benefit from the care we're giving. That's what it's all about, honestly. Thanks for hanging out with me for this episode. Nursing pharmacology is a lot more than just giving medications. Next time, we'll dive into even more exciting aspects of the topic.